One of the most fulfilling aspects of working as a consultant is being able to interact with a variety of colleagues, infection preventionists, nursing staff, surgeons, and perioperative team members, to name a few. All of these individuals contribute valuable perspectives and expertise, and they inspire care and compassion while working together through the process of improving surgical care and reducing incidence of surgical site infections. The ultimate satisfaction, however, is when a surgical team actually takes to heart the recommendations you've discussed with them for implementing key components of the SSI prevention bundle. And down the road, they come back to you and share the fact that SSI occurrence actually decreased following implementation of those recommendations. It's a remarkable reminder that the SSI prevention bundle is not a theoretical concept, but is sound science that, when consistently practiced, makes a positive impact on our surgical patients. And that's what I like to share with other surgical teams as I continue my visits in other places. Keep pushing, keep striving toward 100% compliance with those evidence-based SSI prevention strategies, because then you too will see more of your patients experiencing good surgical infection-free outcomes. And how great is that, to have the confidence that this person being wheeled into the operating room will have the best post-operative recovery possible and can get back to his or her life as soon as possible. There are so many facets of SSI prevention to consider, but one strategy that dates back several years and perhaps needs broader implementation is the idea of prehabilitation of patients. That is, the process of bringing patients to their best level of health possible as they prepare for surgery. Steps such as smoking cessation, weight loss if needed, and optimizing nutritional status have been shown to help patients avoid certain surgical complications, including SSIs. Surgery is a huge insult to the body, and every surgical procedure results in bacterial contamination of the surgical wound. There's no getting around that. But optimizing surgical patients' health gives them a better chance of preventing this contamination from developing into full-blown infections. Additionally, there are several new technologies with good evidence of SSI prevention capacity, but have not been as widely adopted into routine surgical care as they might be. So antimicrobial sutures, for example, have been shown in several meta-analyses to reduce SSIs, and they have excellent safety records. Another example of an underused technologic solution is the use of antimicrobial post-operative wound dressings containing either silver or CHG, both of which demonstrate antimicrobial properties and thus reduce antimicrobial growth at the wound site. They promote healing and keep the surgical site protected for several days until the wound is fully healed. When I was practicing as an infection preventionist in an acute care setting, one of the issues we had with post-operative care was that providers were disturbing the dressing within 48 hours after surgery, because of course they wanted to assess the surgical wound. But this practice increases the risk of wound contamination. The antimicrobial dressings allow the surgical wound to remain covered for up to 7 days when the wound has been fully healed. Providers, however, still like to assess the dressing in many cases, and so the CHG dressing, with its transparent properties, allows for ongoing post-operative wound assessment without disturbing the dressing. Then everybody's happy, including the patients who don't have to worry about dressing changes once they're home. These are just a couple of examples of innovative strategies that, when incorporated into a comprehensive SSI prevention bundle, can really help further drive SSI occurrence downward. Well, first, and this does sound like a cliche, but impeccable communications among all members of the surgical team is one of the crucial steps to promoting quality surgical care. Sometimes team members are reluctant to share their observations, and they simply create workarounds to the problems they see. Here's a real example. In observing an orthopedic procedure during one of my consultations, I noted that the patient was hypothermic, and in visiting with the anesthesiologist, she shared that this occurred frequently following the decision to discontinue the use of active warming devices in the preoperative area. This problem was not shared with the rest of the team, however, and the anesthesiologist simply continued doing her best to maintain normothermia, but was not usually successful. Once we were able to bring this issue to the attention of the perioperative team during a briefing session, the team worked together to find a suitable warming device in the preoperative area. That meant that patients were now sufficiently warmed prior to surgery, hence normothermia was more likely to be maintained intraoperatively. Talking, sharing, communicating, when that occurs among team members, the patient benefits. Secondly, I think surgical teams should feel free to become early adopters of innovative technology that has promise to mitigate SSI risk among their specific patient populations. Sometimes we want to wait for evidence from large, randomized, controlled trials, but those are uncommon these days, and waiting for more can often mean less for our patients. Consistent results from multiple good quality improvement studies also make for compelling arguments to adopt technologies and strategies that can help your patients. And I encourage surgical teams to consider innovations that address their particular patients' SSI risks. Finally, as we learn more about the importance of both prehabilitation and post-operative care strategies, it will become even more important to include partners along the care continuum in the surgical care quality improvement process. So I encourage surgery centers to reach out to their outpatient partners, their home health partners, their rehab professionals, as well as nutritionists, patient educators, and others to engage them in surgical care improvement processes from the start. I urge surgical teams to take greater advantage of the contributions these professionals can make to their surgical patients' well-being.